Visible? So this is a 62
Yes,
years
sir.
old lady from case of bronchial asthma, hypertension, has a lump in the left breast. SPNSC reported to adenocarcinoma, posted for left modified radical mastectomy with axillary clearance. So again, every time when they give a case scenario like this, analyze the case. It's a 62-year-old lady. Was 65 and above is pediatric, but anything above 60 also is a considerably older patient. Comorbidities here are bronchial asthma and hypertension. See a breast stage not known or neoadjuvant. Now that we have said neoadjuvant therapy has been given, it adds to the complication of chemotherapy-induced changes in the patient. In history taking, assess the chronological versus biological age problems. Duration, severity, and treatment or control of comorbid conditions. Duration of malignancy and any pre-op chemo or radiation therapy taken. Especially radiation will cause more tissue damage and the restrictions, especially in the breast if it is not properly. Nowadays we got the linear accelerator and other types of radiations which focus only on the tumor cells and not causing any damage to the normal tissues surrounding the malignant cells. Then pre-op evaluation, general examination, BP control, asthma control, drug therapy, and if any neoadjuvant therapy given, effects of chemo or radiation on various systems, and pre-op investigations as routine for any surgery, then evaluation of CVS and RS due to hypertension and bronchial asthma. Then pre-op instructions, because this is done as an elective, you have to advise NPO medications for hypertension, bronchial asthma, which one you can continue or withhold, anti-anxiolysis, anti-aspiration drugs, and IV fluids if patient has severe nausea, vomiting because of chemo and has been dehydrated, you may have to start IV fluids even during the NPO time. And intra-op management, choice of anesthesia. Previously, we were giving VA with DTQ and thoracic epidural for pain relief. That was the conventional method with which we started doing all breast surgeries. But nowadays, we are able to do this surgery without GA by what is called the anterior approach blocks, which include pectoral nerve, serratus anterior plane block, interpleural, intercostal nerve blocks, or posterior chest wall blocks. There are thoracic epidural, paravertebral, and erector spinae blocks. So it is easy to remember the blocks in this way: anterior blocks and posterior blocks, or thoracic segmental, which we discussed some time ago while discussing in the theory question. This can be the technique of choice, injecting a subarachnoid block in the T6, T7 level with a smaller volume so that only the thoracic segments are blocked so that the patient will have acute pain relief in the breast area. Or you can nowadays do what is called minimal pain permission local anesthesia injection for wide awake modified radical mastectomy. So they are doing the entire mastectomy and axillary clearance also with volume of local anesthesia injected with even no sedation and no general anesthesia. We are able to manage these cases in all patients, even sick patients who are fit enough to undergo regional or GA. It can be managed with minimal pain permission local anesthesia technique. The questions that you have to expect to hear is treatment of bronchial asthma and management of intraoperative bronchospasm in case they give the case with a comorbidity like bronchial asthma. Then control of hypertension and all about hypertension and anesthesia. Chemo drugs used in the breast cancer and their implications. Radiation and its effects and its interactions with the anesthesia. Nerve supply to the breast area and the areas of surgery. Can you tell me what is the nerve supply to the breast area, Pune?
Yes, sir. Sir, medial and lateral branches of thoracic intercostal nerve, sir.
Very good.
Supraclavicular nerve, sir. And medial and lateral pectoral nerve, sir.
In and lateral pectoral. Prof, non-thoracic nerve is also there. There's a performing anterior and posterior chest wall blocks. Also, you need to be aware of technique of doing that using ultrasound and all about emission local anesthesia. Okay, these are all the questions that you have to prepare for answering this posing head with a case like this. Segmental spinal anesthesia, which is thoracic segmental, that question also may be asked. Okay. So these are all the points that you have to remember while discussing about this TA case. Sometime back we discussed about TA tongue. So at the time, I think it was for MEAT students, isn't it? Or early students.
I gave of Perambur.
We had a discussion for Perambur students. So any cancer which can be kept in the exam, you have to remember the points about chemotherapy agents and their effects on the various systems, and the anesthetic agents which have their effect on the cancer cells. So these two things you have to be very clear and be able to answer. Okay.